Hello again, this is Kamran Bhopal and I'm back again for some more questions for the ST3 urology interview. This is the stones station and we've done a history already, and you can have a look on my previous videos how you would take a history of stones in an outpatient setting. Some of the questions that they can ask, obviously if I didn't mention the examination in my previous history video, but you can say I will look for general health performance status, BMI, and palpate for flank tenderness. That's about it. You don't really have to say too much in the examination in stones. They can ask you about investigations, and you can say I would do some urine investigations including a urine dip, look at the pH, and also microscopy and culture and sensitivity, a urine spot test for cysteine, and a 24-hour urine in high-risk patients. Bloods including full blood count, Urinary, calcium, magnesium, phosphate, and uric acid, so stone bloods. Imaging, we should do a CT KUB to assess stone burden, but ultrasound KUB is an alternative in patients who cannot have a CT KUB for any reason. Then DMSA scan to look at the split kidney function can be considered in staghorn calculi or even in smaller stones in which we feel that we can give the option of a benign nephrectomy basically, or if the patient has got chronic flank pain or something like that, which the patient has developed over a prolonged period of time, we can get rid of the kidney if there's no function in that kidney. So DMSA can be considered. Usually in staghorn calculi, we would consider it if the cortical thickness was less than normal. Then we've got stone analysis. So if there's any stone analysis present previously, or if the patient, sometimes patients actually bring the stone to the clinic, so you can send that off for stone analysis. So as I said, urine, bloods, imaging, stone analysis. What are the treatment options? Conservative management and surgical options. Conservative management, you've got increased fluid intake, plus minus acidify, dissolution therapies as well, such as potassium citrate, sodium bicarbonate, which cause alkalinization of the urine. They're usually used in uric acid and cysteine stones. Then weight loss, dietary advice to reduce salt and protein, and surgical options, which are ESWL, ureteroscopy and laser stone fragmentation, and PCNL, and benign nephrectomy in select cases. And now you have to D it accordingly, so you need to know about all of them. Laser stone fragmentation with a ureteroscopy, PCNL, and benign nephrectomy, and the importance of DMSA in the benign nephrectomy, and in what cases would you use these. There are some specific questions. When would you not consider ESWL, for example? So that would come later down the line in my extra questions video, which I gathered. ESWL in pregnant ladies, you can't do it. If patients got a stent, you can't do it. If in renal cancer, patient on anticoagulants, if the patient is obese, if the patient has an ongoing infection, or the patient's got too much pain or low pain threshold. But I would go over that question separately, and because I've got it in a different notebook, I would come to it in the extra stations part. That's about it. So I'll see you next time with another video with the questions relevant to the outpatient scenarios and emergency scenarios moving on. So keep on watching, and all the best, and hope you all get a national training.